Start sharing screen. Thank you. Thank you. Good afternoon, everybody. I'm Dr. Sarang Puranik. I'm working at Kingston Hospital NHS Foundation Trust as a consultant in anesthesia and pain management. So today, I'm going to talk to you about acute pain management. So what is covered in the talk? I'll start with understanding of pain and its anatomical pathways, then go on to importance of pain control. Then I'll talk about evaluation and causal. Okay, let me. Hello, can you hear me? Okay, so I'll say share screen. Uh, yes, hello there. Good afternoon. Can you all hear me? If you can hear me and see me, please send message to Ian. No sound, because as far as I can see, let me check from my side whether I have my. So this is, it was mute for a second ago, so that means that it's not mute from my side, and you can hear me, I guess. So no indication from the audience whether they can hear me. Can they see me or the presentation? Oh, we can hear. They say we can hear. Ian. Hello? Okay, so I'm getting message to continue. So I'm just going to skip over my introduction, which I hope you have um, got it. So I was looking at this screen before I stop, and so this is what I'll be covering in my talk today. In case by any chance if you didn't hear me or see me at that time. Um, so in terms of acute pain, pain of recent onset and probable limited duration, it usually has identifiable temporal and causal relationship to injury or disease. So we are going to talk about acute pain, but we need to know what does mean by chronic pain at the same time. So as I mentioned, acute pain is of recent onset and limited duration, but the pain becomes chronic if it is lasting for more than 3 months, or if the pain is lasting after normal healing. And sometimes there is no identifiable cause in chronic pain. So if you look at the basic simple model of acute pain, what we have is stimulation of peripheral nociceptor, which then initiates pain impulse and transmission down the axon. Then there is release of transmitter at synapse, which then in turn activates spinal neuron, and the stimulation of spinal neuron then leads to onward transmission to brain. And that is really simply what the basic acute pain is. Obviously, we know that pain is complex, subjective experience comprising a sensory and an affective dimension. Pain signals are carried in the nociceptive system, which is a part of somatosensory system. The nociceptors are the free nerve endings of A delta and C primary afferents, which are thinly myelinated and unmyelinated nerve fibers. When they are stimulated with stimuli such as noxious, chemical, or heat, they transduce the signal through the nerve fibers, and these nerve fibers synapse in lamina 1, 2, and 5 of the dorsal horn. The secondary afferents then ascend in various spinal tracts to synapse with third order neurons in the thalamus. The third order neurons project to the midbrain and limbic system, which is responsible for affective dimension of pain, and somatosensory cortex, which is responsible for sensory dimension of pain. As a result of this, what we see is withdrawal reflex, conscious perception of pain, and an emotive response. So no pain talk can be complete without mention of this. A gate control theory was put forward by Melzack and Wall in 1965. Basically, this theory introduced the concept of higher center control. They proposed that small fibers such as C and A delta fibers activate excitatory system, which is balanced by A beta fibers, which are large fibers, which are under control of inhibitory higher centers. So obviously, whether the gate control theory still is important, because there are a lot of advances following that, but the basic concept still holds true. This was also seen and put in 90s. If you simply see on the left side, shows ascending nociceptive pathways, as I mentioned, with the stimulation of nociceptors going up to the brain. But there is also on the right side descending inhibitory control, which starts with activation of serotonergic and noradrenergic pathways, which in turn results in release of serotonin, noradrenaline, and enkephalins at spinal level. In the last 2 decades, there has been quite a lot of advance in terms of molecular understanding of pain transmission, along with finding of various neurotransmitters and research on receptors, as well as different pain models. And we now know a lot more about what happens, and we will talk a little bit more about that. But the basic concepts still are fairly similar in terms of pain pathway and its modulation. So coming to clinical types, if you look at how we can look at the pain in clinical classification, we can classify that as nociceptive pain, which are, as I mentioned, transient pain in response to noxious stimuli. Then inflammatory pain, which is spontaneous pain and hypersensitivity to pain in response to tissue damage and inflammation. And neuropathic pain, which is spontaneous pain and hypersensitivity to pain in association with damage to or a lesion of the nervous system. So what about visceral pain? Visceral nociceptors are similar to A delta and C nociceptors found in the periphery, but the main difference being that they respond to distension and ischemia rather than cutting and thermal damage. Visceral pain signals are carried by A delta and C fibers, which travel with autonomic efferents. So coming to treatment of pain, why do we want to treat pain, you may ask? Obvious reason being strive towards excellence in treatment, And last but not the least, development of chronic pain, which is also termed as chronic post-surgical pain syndrome, which in turn has effects on quality of life as well as public health, as these states can go on for months and years. So as I mentioned, what are the consequences of unrelieved pain and what are the changes in pathophysiological changes on various systems? So we'll start looking at all those systems starting from the left. It may increase the sympathetic activity, which in turn leads to myocardial oxygen consumption increase and leading to myocardial ischemia. So we know for that reason that chances of MI and cardiac events are much higher in the post-op period. On GI, it leads to reduction in GI motility, hence delayed recovery. On the respiratory system, it may cause splinting and shallow breathing, which leads to atelectasis and hypoxia and hypercarbia, leading to pneumonia. On endocrine system, there is increased catabolic demands. As a result, you get poor wound healing and muscle breakdown, which leads to weakness and impaired rehabilitation. Then there is anxiety and fear, which leads to sleeplessness, helplessness, and psychological effects on patients. On top of that, there are changes such as peripheral and central sensitization, which I will come to in a little bit more details, and then it may cause chronic pain as a result. So peripheral sensitization and central sensitization, these are the two important words you would like to know when we talk about any inflammatory pain or chronic neuropathic pain. These are the changes which are happening at the time when, for example, uh, there is unrelieved or inadequately treated postoperative pain, for example, and there are various other reasons why you may get neuropathic pain. So coming to peripheral sensitization on the left of the screen, as you can see, the tissue damage, inflammation, and increased sympathetic activity can lead to release of various nasty chemicals such as histamine, prostaglandins, cytokines, potassium ions, bradykinins, leukotrienes, nerve growth factors, and in fact, all of these has been termed as sensitizing soup. All of these result in increase in the sensitivity in the nociceptor, and the barrage of activity leads to input and causes central sensitization that increases activity dependent excitability of the dorsal horn neurons, and there are changes in the central system with modified responsiveness to nociceptors as well as low threshold mechanoceptor, which are large A beta fibers, leading to allodynia. So that is also depicted in this nice slide. As you can see, tissue damage and nerve damage leading to increase in the peripheral activity. All that activity and all that chemicals releasing to the spinal cord in the central nervous system, which is affected by decreased threshold to the peripheral stimuli, causes expansion of receptive field, increased spontaneous activity, and as a result of this, what we see in the patients, they present with what we call as hyperalgesia, which is heightened pain response, spontaneous pain, and allodynia, which is pain response to even touch and pressure. These are the commonly found features in chronic neuropathic pain patients. And if you have come across these patients, for example, post-herpetic neuralgia, you will never forget that. So coming to management, it is important to know that pain management concerns all patients. So you may have patients with acute pain, but they may have in background chronic pain related issues as well as cancer related issues. So it's important to know that even if the patients may come with chronic acute pain, they may have all these in the background as well. And you may need to address and think about all the other issues. So before even we embark on pain treatment, it is important to know and consider various factors because pain is individual. There are various behavioral, psychological, and social factors. Previous experiences can affect pain responses. And we know, for example, if you had really bad experience of cannulation or any painful issues in your childhood, adults, when they come for surgery, they're very anxious. Their response to pain can be different, or even if they come to hospital, they may have different reaction to their pain. Different cultural backgrounds have different way of responding to pain, and you can see their reactions when they come with a different quantity of pain. For one, can be different to different person in different cultural backgrounds. Then there are consequences of pain in the past, which is there in the background, can cause heightened pain response. For example, if they had something gone bad in the previous surgery, or if there is a loss of employment and they come with some issues with acute pain, the expression of pain and experience of pain can be different. And we know that coping styles are different in terms of individual patients as well. On top of that, fear, anxiety, and depression all can either increase or decrease the response to pain. But ultimately, the plan, when we look at it, the main aim is to keep it simple. You start with bottom of the page, start with pain assessment, and start thinking about WHO ladder, which I'll come to in a few minutes. Then think about which drug and which route, and then test the plan and see if that works and reassess. So what do I mean by physical assessment? Essentially, what we need to look at is location, its intensity, quality, and nature of the pain. So you start with where is the pain, how much does it hurt. So in terms of how much does it hurt, there are various scales available, which we will look at in a minute. Then it's important to find out in their own words, what does it feel like? For example, is it aching pain, sharp pain? Is it dull ache, etc. in their own words? And if they can't think about the words, then there are various charts with the words you can show them and they can circle those, which will tell us if the pain is lancinating, burning type pain, which will give us some clues about whether the neuropathic element is there, etc. Then you look at onset, duration, and variation, such as for how long the pain has been there and whether it is more when they breathe or cough, or whether it is worsening after movements, which will also give us clue about whether they are actually able to control their pain better, how they are able to express their pain, whether they are grimacing or whether it is impossible to bear and they are writhing in pain. Then also find out about what relieves it and causes increase in pain, and then what current analgesic they are taking. Once you have found out about that, uh, in terms of assessment, it's also obviously you can get what the patient tells you, their facial expressions, as I mentioned, refusal to move, cough, and deep breaths. You will also be able to see from their findings if there is high blood pressure, tachycardia, sweating, and dilated pupils. So you can get those clues from their assessment. And coming to scoring of pain, as I said, when we want to know how much pain they are, and when we want to convey our message to somebody else in terms of treating the pain, there are various scoring scales available which are commonly used. And first one is verbal numeric scale, which is depicted here in the picture, which gives you pain scoring on numeric rating, 0 being no pain and 10 being the worst pain. And you can ask the patient to score where their pain is. To indicate what sort of phase they can choose from. So it's much easier to rate their pain with the help of these scales. So it's important that we approach any treatment of pain in holistic manner, considering their mood, thoughts, behavior, and the physical pain. So coming to specific treatments of pain, we know now what nociceptive pain is, which is due to the stimuli such as cold, heat, mechanical force, etc. That is responsive to NSAIDs, coxibs, paracetamol, and opioids. Inflammatory pain, which we know happens due to some sort of inflammation and tissue damage, and then it leads to spontaneous hypersensitivity, allodynia, hyperalgesia, that is responsive to NSAIDs, coxibs, paracetamol, and opioids. If you are dealing with neuropathic pain, then it may respond to local anesthetic, anticonvulsants, or antidepressants, as well as it's important to know that opioids are not very useful for treating neuropathic pain. And hence, we've come across patients who complain of neuropathic pain and they've tried paracetamol, NSAIDs, coxibs, and they are not really useful for them. So we need to consider drugs such as anticonvulsant and antidepressant for these treatments. It's important to know that postoperative pain is generally nociceptive pain, and it is responsive to all such as NSAIDs, paracetamol, coxibs, and opioids. So coming to basic principles of acute pain management, aim should be there should be no pain at rest and minimal pain on coughing or movement. You need to assess the site, nature, and severity of pain and tailor the treatment accordingly. You need to select and start the most appropriate treatment modality, considering the contraindications and allergies to the patient. And once you started the treatment, it's very important to reevaluate the effectiveness and alter the pain treatment accordingly. Also look out for side effects and see at times the side effects can be more distressing than actual treatment of the pain, and hence you may have to change the treatment management plan. There are some other important principles which you need to look at. Give regular pain relief, especially in terms of post-operative pain management, and don't keep it PRN. In fact, PRN in these cases could be said as pain relief nil, because what they need is most of the time by mouth, by the clock, and by the ladder. Ensure analgesics are available for breakthrough. Use the right drug for the right pain, as we have gone through. Use the analgesic ladder, titrate and reassess. And I'm going to the ladder. What do you mean by ladder in next slide in a minute, which will give you idea about when I say what you use by ladder. Use adjuvants if necessary. In elderly patients, it's important to go very slow and start at lowest dose possible. And also it's important to be aware of health problems which can affect their absorption, metabolism in terms of their renal and hepatic issues as well. So all these things are important before you embark on any pain treatment. Coming to the WHO analgesic ladder, this ladder was proposed by WHO in 1986 for treatment of cancer pain. And simply put, it's very simple way of thinking and remembering, especially at that time, what is the best way of treating pain and how to start initial treatment of pain in stepwise manner. So you start with simple medicines such as paracetamol, NSAIDs initially, and if that pain relief is not adequate, then you go up on mild to moderate opioids in addition to that, and then ultimately going to stronger pain relief. Even though it was proposed for cancer pain, it has been now used for all pain treatments to think about whenever we are starting any patients. Whenever you see any patients on the ward in A&E, always think about ladder and start with something mild depending on their pain. Obviously, if the WHO ladder is relevant at this stage, because it was simplistic way of looking at it, and there are lots of adjuvants and different analgesics, which such as anti-epileptics and tricyclic antidepressants used for neuropathic pain. And you may want to start, for example, strong painkillers if you already know the pain is severe, for example. So, but it gives you a good idea in terms of when you're thinking of initially how to start with the pain treatment. So that is the reason I talked about ladder, and it gives you clear-cut idea when I say start by the ladder and use the analgesic ladder. So I'm going to come to some of the commonly used drugs in pain treatment, starting with paracetamol. It's actually quite effective in acute pain treatment, and most of the time its effects are underestimated. It can reduce opioid requirement, for example, by almost 30 to 40%, and it can enhance the quality of opioid-based analgesia. The dose is generally 1 gram QDS to maximum 4 gram. But if you increase the dose 10 to 15 gram or more, it can cause irreversible liver damage. You probably know that it's already been given in IV format as well, which is quite effective, but it's oral, PR, and IV are the commonly used routes. So coming to mechanism of action of paracetamol, there is good evidence that there exists COX-3 enzyme, which may be inhibited by paracetamol. Paracetamol certainly inhibits prostaglandin synthesis within the central nervous system. So it has some central action as well, especially the E series from the anterior hypothalamus. On top of that, it also appears to have peripheral effects in that it inhibits bradykinin sensitive chemoreceptor transmission. So it's quite perplexing that even commonly used drugs such as paracetamol have a difficult to know mechanism of action, and it works on peripheral as well as central system. NSAIDs, very good for inflammations, musculoskeletal, gout, and most of the postoperative pain. They can reduce opioid requirement as well and enhance quality of opioid-based postoperative analgesia. The action is by blocking cyclooxygenase and hence prostaglandin synthesis. As we probably know, there are two isoforms of cyclooxygenase inhibitors, COX-1 and COX-2. COX-1 is important in routine physiological function, and COX-2 is induced by pain and inflammation. So there are selective COX-2 inhibitors available to use for patients with history of gastric irritation, for example. So from then on, it's important to know the contraindications of NSAIDs. As I mentioned, GI symptoms and peptic ulcer disease. If there is any degree of liver or renal failure, you have to be cautious. If there is history of previous organ transplant, known heart disease or stroke, you have to be careful. There may be patients with asthma. Not all the patients are sensitive to NSAIDs, but it is very important to find out before you start any NSAIDs to ask them if they had any NSAIDs before and if it exacerbates their asthma. There is also bleeding risk, especially if they're on any anticoagulants and they're on any disorder, they have any disorders, and if they're on heparin, and if they are dehydrated, if the urine output is reduced. Generally, ibuprofen is commonly used NSAIDs starting at 200 to 400 milligram TDS or QDS. And you could use either naproxen or diclofenac as second line, starting with 250 milligram 6 to 8 hourly and diclofenac 50 milligram TDS. Apart from drugs, before going on to any stronger medicines, it's important to know about Entonox. Very useful in settings such as an emergency, and you probably know it's used on maternity wards. Entonox is mixture of oxygen 50-50 and nitrous oxide. Nitrous oxide is the one which produces pain relief. There are cylinders available which can be given to patients as self-administered via face mask or mouthpiece. With the help of trained staff, they can use them. And the effects of these are apparent within a matter of breaths, with peak analgesia within 2 minutes. In fact, the effects are compared to those of opioids, and it can be equivalent to 10 milligram or 100 milligram of pethidine, and it offers, as I said, rapid analgesia with speedy reversal of effects when required. So as you can see, as soon as you stop breathing, the effects of analgesia reduce, which has added advantage. And it's important to know that these can be easily used in accident emergency settings or even on the wards when you are doing things such as dressing changes, manipulations, and physiotherapy. So coming to opioids, are suitable for moderate to severe pain. Most of the opioid sensitive pains are
pain such as
pain such
postoperative
as
and cancer
postoperative
pain,
and cancer pain,
but the muscle spasm and deafferentation responds poorly to opioids. And there are some partially opioid sensitive pain issues, such as vascular pain, nerve compression, and metastatic bone pain. So you may still use them, but you may need to add other adjuvants and other medications with them. It's important to know that only one opioid should be used at a time to ensure that doses can be worked out and you can titrate the doses slowly and find out which analgesic works better. So we have choice of opioids. So if you look at the list of opioids, weak opioids are codeine, just to remind us the dose, 30 milligram generally, starting with maximum 240 milligram per day. Dihydrocodeine, 30 milligram, again 240 milligram maximum per day. And then we have tramadol, 50 milligram, with a maximum dose of 400 milligram per day. And then we have strong opioids such as morphine, oxycodone, fentanyl, diamorphine, pethidine, and buprenorphine. In last 10 years, there has been an issue with codeine. In fact, there was a MHRA um, update on codeine, and they have now restricted use of codeine in children because of morphine toxicity. What they say is codeine should only be used to relieve acute moderate pain in children older than 12 years and only if cannot be relieved by other painkillers such as paracetamol and ibuprofen alone. Furthermore, they say there is a significant risk of serious and life-threatening adverse reactions which has been identified in children with obstructive sleep apnea who receive codeine after tonsillectomy or adenodectomy. And in fact, we do not use codeine routinely in children after these ENT surgeries for the almost last 8 to 10 years now. So it's important to know, and in post-operative and intraoperative setting, another important issue is it should never ever be given IV because of its severe histamine release and severe hypotension. And if it is used during intraoperative period, as we all know, has to be used intramuscularly. Then coming to tramadol, its opioid effect, it's a mixed medicine in terms of its actions. It has some opioid effect, which is dependent on its metabolite, which is O-desmethyl tramadol, which is metabolized by the cytochrome enzyme system. And as we know, this enzyme system is subject to genetic variability, which is similar to codeine as well. However, only third of its analgesic property is due to opioid receptor stimulation, and alteration of neuronal transmission of norepinephrine and serotonergic action in the CNS is thought to contribute to its analgesic effect as well. Some of the common side effects of this tramadol are headache, nausea, vomiting, dizziness, and it's important to remember that it decreases seizure threshold. So either you should avoid it in patients with history of epilepsy, or you have to be very, very careful. There is low potential for respiratory depression and addiction as compared to morphine, and it has no clinically significant cardiovascular effect, as well as constipation is uncommon. As we know, tramadol can be given orally or intravenously, as well as intramuscularly. So coming to strong opioids, uh, fentanyl is available in patch form or even lollipop form, where you can suck the lozenges, and intravenous. Fentanyl patch is quite strong in terms of its dosages. For example, 25 microgram patch is equal to almost 90 milligrams of morphine per day. And this patch comes as a 72-hour patch, which you change after 72 hours and put another patch. Then you also have butrans patch, which is buprenorphine patch. Generally, it is available as a once a week, and 5 micrograms is almost equal to 30 to 60 milligrams of codeine per day. 10 micrograms patch is equivalent to 60 to 120 milligrams of codeine per day, etc. Diamorphine, which is generally used as a subcutaneous, uh, it is 3 times stronger than morphine and also used in quite a lot in palliative care patients um, in terms of keeping the patients under pain control in their um, last few hours, etc. And most of the common route is subcutaneous pump, for example. Uh, then we have pethidine, which can be used in oral, intramuscular, or IV in the dose of 10 to 50 milligrams. So you need to remember different routes of opioid administration, such as oral, parenteral, transdermal, neuroaxial, transmucosal. As I said, lozenges are available, as well as some other routes, such as intraarticular form available as well. Important to know the side effects which are associated with opioids. And as you can see, nausea and vomiting consist of majority of them, followed by constipation. And then you can get itching, hallucinations, mood alterations, and dizziness, which are also seen quite commonly. Another mention of constipation, as you can imagine, all opioids are constipating, and tramadol is less constipating amongst all. Hence, all patients we suggest on regular opioids should be written up for laxatives. It is important to do the titration of oral opioids. For example, if you are using oral morphine, use small doses of short-acting oromorph regularly, and on top of that, use PRN for breakthrough until the dose can be stabilized 24 hours later. So, for example, you can start with 5 milligram orally, 4 hourly, and then 5 milligram PRN on top. Once the MST dose is established, work out the breakthrough analgesia at 1/6 dose to be used hourly if necessary. So you can use, for example, 30 milligram morphine sulfate BD, which is 60 milligram morphine per day. So for that dose, you can start with 60 by 6, 1/6, which will be 10 milligrams oromorph as and when required. So you cover the breakthrough pain as well as regular pain on top. So that's about generally the oral and parenteral analgesia. Coming to epidural and PCA analgesia, generally these forms of analgesic methods are used for major surgery for post-operative analgesia, as it is important to know that regular observation and evaluation is really necessary if you're using any of these. So these practices are best done and used in institutional settings. So for those who have not come across this, especially for medics in audience, as well as um, anesthetic trainees who are in their first few months or year, epidural analgesia combines low dose concentration local anesthetic generally, and you can use it with combination of opioids or with local anesthetic solely. If you use them intraoperatively, It allows lighter level of general anesthetic, so we can use lower concentration of inhalation anesthetic. We can use less intraoperative opioids because we are able to use uh, epidural, local anesthetic, as well as opioid if necessary, delivered by neuraxial route, i.e. epidural route. So that also diminishes the requirement of muscle relaxant, and hence their side effects can be reduced, and you can have much less dose of anesthetic during intraoperative period. In addition to that, it also gives reduced intraoperative bleeding advantage. So as I said, for epidural analgesia, it is generally a combination of local anesthetic and opioid. Um, so side effects such as motor block and respiratory depression are avoided if you use low dose of local anesthetic as well as small dose of opioids. As also, if you are using opioids neuroxally, it avoids the side effects of systemic local opioid administration. You get superior analgesia and less respiratory depression, which allows patients to deep breathe and cough effectively, which ultimately reduces the incidence of postoperative chest infection and atelectasis incidence. In addition to that, it allows earlier mobilization and hence lowers the uh, incidence of DVT. Generally, what we use in epidural analgesia is, as I said, low dose, which is 0.125% bupivacaine plus fentanyl, but you can also use diamorphine, and you start infusion at a rate anywhere between 2 to 15 ml per hour, depending on the age, site of incision, and level of insertion of epidural catheter, etc. And you assess their hemodynamic response. If we have given stronger local anesthetics, then it has effects on their blood pressure, which can lead to hypotension, and you may need to give them vasopressors or fluids. And it's important to know that if you are using opioids through the epidural route, you should not be giving systemic opioids at the same time. And in case if there is any issue of opioid excess, it's important to remember naloxone if you get especially the respiratory depression. Coming to patient control analgesia, um, there are different types of machines available. This is just one of the machines which is commonly used. It's ideal for uh, major surgery because what we need in these type of machines to use is opioids which have rapid onset of action as well as high analgesic efficacy with no ceiling effects, and they should have intermediate duration of effect for better controllability. And morphine and pethidine are quite close to satisfying the criteria, but you could also use tramadol in the mixture when you're using PCA. So you can have background infusion in the prescription as well as patient has control. So patient will just press the button and they will get a predetermined dose of opioid as said by the operator. So this helps in terms of higher trough levels of opioid, which um, otherwise you will get up and down effects of systemic opioids if you're giving them IV or intramuscularly or even orally. Obviously, you need to remember the risk of respiratory depression is there as well as sedation and other side effects, and hence it is best practice in institutional. So it is indicated, as I said, for anyone needing repeated doses of opioids. it is important to know that there is a non-written wall available on the settings, and no other opioid should be used once they're on opioid PCA. The general regime, what we use in most of the places is a standard 1 milligram per ml PCA dose of morphine with 5 minutes of lockout. And you can adjust the 4-hourly dose depending on the patient characteristics. But in general, 40 milligrams 4-hourly maximum dose is set as a standard. Before you start using opioids in PCA, it's important to know the side effects. So it's important to know the patient's renal function, as most of the opioids and their metabolites are excreted renally. The renal function is compromised, then there is accumulation and side effects may occur. So careful selection of opioids and avoidance of infusion techniques will permit safe prescribing in these patients. It's also important what to do when you discontinue the PCA or epidural, because these are used generally for 48 to 72 hours in the post-operative period. But when it is time to discontinue, they will need regular analgesia for at least 48 hours post discontinuation of PCA or epidural. You may want to discontinue them as well. You have to remember if there is inadequate action or if they need any analgesia for breakthrough pain. So standard analgesic regime in these circumstances, you could start with paracetamol 1 gram QDS on the regular side, along with codeine 30 milligram QDS, or tramadol 50 milligram QDS, or oxycontin. And you could add NSAIDs along with that if they're not contraindicated, obviously. So just a quick recap of what you can do in terms of what to use uh, when you need to use common methods of pain relief. If you want to choose oral or rectal, you can use non-steroidal, because you know that Voltrol, for example, is available in a suppository form as well as paracetamol. Important to remember the side effects such as renal, as I said, um, issues, renal failure, and peptic ulceration. Um, Treatment being stop the drug. Intramuscular, you can use opioid. Side effects being respiratory depression and worse, coma. So remember naloxone. IV, again, you can use opioid, respiratory depression, and changes in their dizziness and coma. And remember naloxone again. And in epidural, generally use local anesthetic with local anesthetic plus opioids. And it's important to remember they can cause either hypotension or respiratory depression or both. And it's important to remember IV fluids, naloxone, vasopressor in case of any eventualities. But it's not just the medical administration and medicines you need to worry and think about when you're treating any postoperative pain. For example, you need to remember there are various peripheral nerve blocks which can be used either during or immediately after surgery, or in fact used on as a sole procedure. For example, you can do various upper limb surgeries with or without combination of general anesthetic with brachial plexus axillary blocks, interscalene blocks, and suprascapular block. You can use different types of blocks in lower limb, for example, fascia iliaca, femoral, popliteal ankle blocks. These blocks are also important in settings of accident emergency. For example, fascia iliaca block is now commonly used in our hospital by the accident and emergency staff on regular basis. on any patients with fracture hip, because that becomes very easier for management of their pain without giving them opioids, as most of these patients are elderly patients. Then they can be transferred from accident emergency departments to respective wards without much pain relief. It also helps when they come for surgery. If you want to position them, for example, you can position them for further anesthesia such as spinal epidural, etc., without much pain. There are blocks which you can use during intra-op period if you don't want to use, or if you can't use epidural, for example, blocks such as tap block or rector sheath blocks. All of these can reduce the opioid requirements and subsequent side effects and the issues with opioids, which we discussed. You can also use spinal plus GA, which again has added synergistic advantages, and use of local anesthetic with additives, which are number of additives such as clonidine, dexamethasone, etc. during intra period can be really useful. And they're also quite commonly used after orthopedic hip surgery, for example, in our hospitals. And we commonly use them even after using spinal anesthesia. At the end of the surgery, if you infiltrate, for example, in a skin and other tissues, it can be useful and enhance the spinal block afterwards for much prolonged period. So it is really important to remember all these adjuvants and blocks along with um, medical management. So what you need to remember is attempts to produce total pain relief with single technique are likely to be associated with major side effects, and hence so-called balanced or multimodal analgesia is used. So in summary, even simple techniques of pain relief can be more effective if the attention is given to education, documentation, patient assessment, and provision of appropriate guidelines and policies. So whichever methods, for example, if you want to institute and have PCA or epidural service available in your hospital, it's important that there are uh, people looking after those patients and observing and reassessing them, as well as documenting and auditing any side effects, any issues. And you'll be not able to find any hospital in UK, for example, without acute pain teams who religiously every day look after these patients when they are put on, for example, epidural and PCI, and patients who have complex pain issues, they are always looked after for that matter. Successful management requires close liaison with all personnel involved in the care of patients. So integrated biopsychosocial approach to management that also considers patients' preferences and their prior experiences is encouraged. Just a few other things. Patients who are on long-term opioids may need weaning gradually after surgery or titrated onto opioids if they are palliative. So what we suggest is if the patients are, for example, opioid users or drug addicts and they come for any acute surgery, that is not the time for them to think about weaning as such of their regular opioids, but certainly all of that can be done only after they have had their surgery. So they may need added opioids treatment while they're having their acute problem sorted. Regional anesthetic blocks will wear off after say 8 to 12 hours unless you have also included um, catheter techniques, which then give continuous local anesthetic infusions. So those patients who get single shot um, any regional anesthetic techniques, they will need regular and PRN analgesia. So whilst the block is working, you have to be careful not to prescribe them any opioids, but start towards the end of their expected weaning period, or when it is about to wean off from that, because they may have opioid side effects, as the blocks may be working and they may still get their opioids, for example. It's important to remember that fentanyl patch, for example, can, can take up to 16 hours to metabolize due to the depot effect. So perhaps not very commonly used in the post-op period, but they have their role as well in select cases. This is another nice way of thinking about when you are starting any pain management teams in your hospital, and radar technique or radar mnemonic is used. R is responsibility, so involvement of whole team and clarity of roles of each person in managing pain is important. Then anticipation, pain should be anticipated wherever possible, and complex at risk patients should be recognized earlier and managed accordingly. Then D, discussion. So peri and post-operative plan should be discussed and shared with all the team members of acute pain team, with particular regard to management of adverse effects. Treatment goals and options should be discussed with the patients. So when the patients come for pre-operative assessment, they should be discussed what sort of pain relief method can be available for them. So it is easier for them when they come for their surgery on actual day. All those are easier to explain to them, and they are aware what should be expected, as well as whole team is then responsible for their pain also is aware. Then comes assessment. Pain should be assessed regularly, and it has been said that it is probably fifth vital sign with standardized tool used throughout the hospital. So it's important to know that the way you assess pain, you then choose which assessment or scale you are going to implement in the whole hospital, and that should be standardized so that everybody is aware what sort of scoring system is available. As I said, if you are using NRS numerical rating scale, then it's easier wherever you are, whenever you are talking to any other person and tell them that the patients involved have pain at whatever scale, it's easier for everybody to understand what sort of pain level they are in. And the response R should be rapid and appropriate. Analgesia administered based on quick absorption to have fast effects, and using multimodal approach to minimize the side effects, as I mentioned before. So in summary, it's important to use pain assessment skills with the help of various scales available, have a plan of analgesia, use and remember the ladder, and most importantly, keep it simple. Prescribe single agents, prescribe regular medications, use appropriate drug, route and mode of delivery, and avoid confused prescribing. Frequent assessment is really important because you can't just prescribe something and forget about it. It's important, for example, in case of acute morphine titration doses, you give some small dose and check how they responded and slowly start adding extra dosages. Do not just prescribe straight 10 milligram dose to anybody and think that that should be enough. Seek help and advice if you are in doubt. Make sure before you start them on any regime that you get seniors advice if needed. So I'm going to, it's a shame that I cannot interact with all of you, and it would have been much easier if we had some interaction so that we could, or all of you could take part in some cases to give you some idea of how you can manage such certain situations. So I'm going to start with the first case, and I believe even if you can't interact with me, you can perhaps um, start thinking about either within groups of 3 or 4 amongst yourself, or if you can't, think in your head and see if you can come up with some answers as we go along. Okay, so first case is you have to assume that you are one of the doctors, maybe either medical doctor, i.e. working on the ward, or if you are anesthetic trainee or someone working in A&E. So let's assume that you are actually, in this particular case, you are working on the ward. There is a 69-year-old patient who is a shop owner who had surgery in the morning for elective laparotomy for diverticular disease, which was done earlier this morning. What we know about him is he's hypertensive, he's on bendofluoride, and can walk to shop without problem, and he's a heavy smoker. He's had general anesthetic plus epidural, and initially when he came on the ward, he was not in pain, but in the last 3 hours, so this is evening, he had surgery early morning, it may be around 9 o'clock in the evening now. So in the last 3 hours, he's experiencing pain on the left side of his abdomen. From now onwards, I want you to think, what is the further management? How we are going to approach this scenario? Even if you're not working as anesthetic or as a surgical or medical or any doctor, I want you to be in the shoes of any doctor who comes across this patient on the ward and you've been called because the patient is now complaining of described pain, and what you're going to do. So I'll give you maybe 2 minutes to think about how you're going to approach this.
Okay, so let's see going forward. Um, some more clues. When in bed, he's sitting in excruciating pain on the left side, especially when trying to cough or move. He's grimacing and breathing fast with arm over his left shoulder. He's also angry that he was told that his pain will be minimal if at all, and now he's experiencing pain even more than his diverticular pain. So, as you can see, there are some more hints. What is happening here? So now you have a little bit more information. You can see that thinking what you have already thought about this before may also change to some extent. And that may alter your thinking even further. Because now you know the fact that he has issues with his pain, which is also more than what he expected. So whatever he's expected his pain would be, or he was told, that is also another issue behind all this going on. So considering all that, what are the next steps? How would you manage that further? So if you want to, maybe for next 10-15 seconds, think about if there is anything different you would do, you could think about that now. Yes, so I think what I would suggest is that keep those answers in either if you have written them or thought about, and we will go through it now. Yes, that's one of the suggestion is good. So the way perhaps we would approach this is obviously, as I mentioned, always start with assessment. And always remember, even if this is not a dire emergency, always start with ABC. Okay, so check whether how is his airway? Is he able to speak full sentences, for example? Is he in such a lot of pain where he can't even speak properly? Is he still fully conscious, etc.? And just by checking his airway, his speech, and the way he's lying on, his facial expressions, whatever I talked about, the way you assess his pain, you'll be able to get a lot of information. Check breathing, check his heart rate, which I think we discussed about, and obviously check his blood pressure, whether he's become hypertensive as a result of inadequate pain relief. So start with ABC. Then I will also look at his OBS chart and see what has been happening over the last few hours, as we know that he had his operation in the morning, and I would like to find out more before giving anything or doing anything, what is happening throughout last 6 hours or whatever hours he's been on the ward. Was he having regular epidural infusion? Whether the infusion was running correctly, whether all the connections, for example, are intact, whether there is any leak, either end. It could be at the patient end or at the device end. And check all that, whether anything has come out, for example, and moved. If the dressing
where the patient was moving quite a lot before, etc. So those things will give us quite a lot of information. Look at his skin, whether he's sweating, whether he's dry, whether he's been having fluids, all those things, and see A, B, C, D. Okay. So you can imagine, uh, on top of that, there is a discrepancy between the expectation and his pain. So already there are some issues in terms of his expression of pain and his pain management. So there are psychological issues as well, or his um, discrepancy between expectancy and his anger is coming out because of his inadequate pain relief. So that has to be managed in terms of how you can start approaching the patient. Okay. Followed by that, I would look at the characteristic of pain, where it is exactly. Is it continuous? Is it sharp? We know that he's not able to cough properly. With the epidural assessment, I will then specifically check the height of the block, what drug and rate was the prescription before, and if he has any other regular medication such as paracetamol, diclofenac, which has been prescribed, and has he received all those things. So LP is a learning point. So assessment and scoring is important. What the scoring has been done before, what are the parameters such as what is his mu score, etc. All those things are important. And then communication. So what I was thinking at this stage is the communication is also important, and address that initially in terms of with talking to him empathetically and communicating that these things can happen and how you're going to deal with the situation, and then find out why it has failed. Obviously, absolutely right. I think it was suggested by some of you that you will think about top up of epidural, and I would probably think of topping up with some stronger concentration rather than milder concentration such as 0.25 or 0.5% bupivacaine. But it's important to know that if you are going to top it up with stronger concentration, you are going to assess the patient for next half an hour yourself. It will become either properly your responsibility or responsibility of any other nurse in your team who is aware of what can happen if you're given a strong local anesthetic, stronger concentration. So all these things are important. And yes, you could give the bolus. Obviously, uh, discuss with the nursing staff, as I said, and reassess and keep an eye. And if that does not work, it may be that the epidural catheter has moved, or for some reason there is a leak or any other issues. You need to think about what next. And you may need to continue with PCA morphine. Remember, he is within few hours, not even 24 hours of his surgery. So he is going to need something stronger, and perhaps ideal thing should be to use PCA morphine and multimodal analgesia. So learning points, he may want to keep a patient comfortable and get the patient comfortable as much as possible. He may not be completely pain-free. You may not you may have to comfort him initially and be empathetic and manage his expectations. You also need to take care of the side effects such as nausea, vomiting, pruritus, and respiratory depression. Um, if the epidural is not working, even after you have given a bolus dose, is it really safe to remove the catheter at this stage? You need to think about it. What is going to stop you removing the catheter? For example, patient may have had his anticoagulant dose. Okay, so at this stage, you may have to stop the epidural infusion, cap it, and then convert it to PCA,
but make sure you do not actually take the catheter out now and wait for whatever period, 12 hours, 4 hours after his last dose of his anticoagulant, for example. You may need to call for help depending on your level of experience and training. You need to know who you're going to call, who is available at that time, whether it is your next senior registrar or your consultant. And it's also important to know that it's not just giving him strong painkiller, but what about what is going on in terms of his previous surgery he had, whether there is abdominal distension, because that is very important rather than just controlling his pain. Especially, you need to remember what are the immediate post-operative complications, whether he has distended abdomen, and in those cases, you may need help of your other friends, such as your surgical colleagues, to come and assess him. Because if he is still having breakthrough pain after you have given strong local anesthetic bolus, for example, and his pain is still not controlled, or he has other signs such as sweating, tachycardia, he could be developing some complications of surgery. So it's very important to remember those when you're treating pain as well. So this is one of the case discussions, but just wanted to point out this is quite good table, which was developed by a Bandolier group in Oxford. Has not been updated as far as I can see, but this gives you idea. What they talk about here in this league table is they have studied lots of randomized placebo-controlled studies, etc., and come up with these league tables depending on their NNT. So single dose analgesic for moderate to severe acute pain and the combination, and which medicines or which analgesics you can choose depending on their NNT, which is for at least 50% maximum pain relief over 4 to 6 hours. So NNT here is number needed to treat, where you get the number of patients needed to be treated for one to benefit compared to a control. So what they have tabulated in this table is all the commonly used and some of the not so commonly used medicines, and gives us a nice table, and it is readily available on at their website for you to look at. And that is it, really. Thank you very much. Any more questions? I mean, I have, if you are interested and keen, another case to discuss, but I will be guided by you. This is one of the recent pictures in England where we had quite a lot of snow within the last week or so. Hopefully, you will cool down looking at this picture. Excellent. So in that, I would say thank you very much, and we can end today's talk. Thank you. Enjoy your day.
Thank you, Sarang.
Cheers now.